Yeah, I'm actually headed over to WashU's School of Medicine. There's a research panel um, on HIV/AIDS, and I was actually just reading the paper, the New York Times, on the front page. We have this article: "Poor Black and Hispanic men are the face of HIV," uh, and so I'm gonna head over here to the research panel. Um, See what's going on in the world of HIV/AIDS research, and hopefully be able to get the perspective from someone over at the School of Medicine. All right.
And I'm I'm a neurologist here, and I've actually been fortunate enough to work with two of these young individuals, and hopefully the third young individual here as well too. As a neurologist, I'm very interested in the complications of HIV in the brain. We know that the virus gets into the brain soon after a person is infected, and it can often develop a reservoir there and continue to divide and replicate even in those individuals.
Okay, so each of you described how your areas of focus relate to a unique facet of HIV infection and its complications. So how do your particular areas of research relate to what sort of treatment you would recommend for your patients, or what sort of treatments you would research?
Well, I'm not a clinician, you shouldn't ask me that question. Defer to clinicians on the board.
Well, I can start. So I work in the Washington University Clinic, where we serve at least 1,500 patients infected with HIV. Right now, since my research is in the aging HIV infected population, so right now in the United States, there's at least 1/3 of the people living with HIV are actually 50 years and older. In other parts of the world, it's like 8 to 10%, but the trajectory in North America and in other parts of the world are also steep. So this is because people living with HIV are living actually longer. Aging impacts HIV in a lot of ways. So as we know, aging independent of HIV infection is associated with development of a lot of comorbidities, from cancer, from cardiovascular events such as stroke or myocardial infarction, and kidney dysfunction, bone disease. HIV, independent of aging, has also been linked to the development of these comorbidities, even in younger individuals. So when you try to imagine two big circles, two strong epidemiologic factors actually intersecting, so we see
we've gone through patients who had to take 30 pills divided up at 5, 6, sometimes even 8 times a day because of the interactions between the medications, to now 3 regimens that are actually 1 pill once a day, containing either 3 or 4 different medications in that regimen. And so when I'm thinking about, so when we thought about treatment, when we first started getting medications like AZT, and with the early onset of a cocktail of therapy, or what they call highly active antiretroviral therapy, or HART, in the
we know less about what's happening in the brain because most of the drugs are not studied in their effects on the brain. They're looking at their endpoints were either their viral load or their CD4 count. So a lot of these drugs are not well known, and what they're doing to the brain is not as well known. And there have been some studies that have been actually conducted here that have looked at how well a drug penetrates the brain. So overall, just as a general aside, as Erica was pointing out, for the numbers for HIV patients, there's over 1 million or so in the United States. We think from research studies that have been done here as well as at other places, about 40% of HIV positive patients will have neurocognitive complaints, and that may be either very mild, mild to moderate, or significant. The antiretrovirals have really changed the whole spectrum of the disorder. HIV used to be, first of all, a death sentence, and second of all, much more of an acute disease. Now it's much more of a chronic disease. We're hearing from what Jerome is saying, and now is also what Erica has been saying. In regards to our thinking,
United States, but before you guys spoke, I was thinking about what are the issues internationally with the epidemics going on around the world, or the HIV epidemic going on around in sub-Saharan Africa, in Asia and India, and the problems associated, I guess, with clinical trials or access to medication, and what you guys think possible solutions or steps could be taken towards those problems.
So we can talk about the epidemiology of HIV in comparison with North America and other parts of the world. In terms of death rates across all the globe, there is a significant decrease in the number of people dying of HIV from like 30 to even like 70% since the peak of the epidemic in the late 1990s with the advent of the antiretroviral therapy. The incidence rate or the number of new infections acquired every year is actually different. So in North America and in a big part of Central and Western Europe, the incidence rate has actually been sort of like stable. In direct contrast to what's happening in Africa, where it's actually significantly decreased. In other parts of the world, particularly Eastern Europe and Asia, the incidence rate is actually increasing. So that's a major difference. And also the mode of acquisition of HIV.
Yeah, I wanted to ask, here in the U.S., what demographic is most devastated by this epidemic and why?
So in the United States, we can speak of the prevalence, which is the number of people living with HIV and AIDS, and the number of newly diagnosed people with HIV and AIDS. So unfortunately, the Black race is the one that's being disproportionately affected by the HIV epidemic. Although, the Black race is comprised about 30–40% of the population, more than half, 15%, more than half of the newly infected patients with HIV each year, and more than half of people living with HIV are actually are Black race. And the main contributor also for the new diagnosis of HIV are the younger MSMs who really drive the new incidence rate in HIV. So there, I would say they are the ones that are being disproportionately affected by HIV. There are a lot of reasons. A lot of epidemiologists actually point to the fact, they can't really explain biologically, but they associate with the psychosocial factors associated with, with the Black race as well as being young, as Erica pointed out. Being young equals, really poor adherence to therapy and really, being scared of being screened as well. And also for the Black race, they're also been associated with, higher risk of having a low socioeconomic status and really no access to care. So a lot of these social factors that are very prevalent in among the Blacks have also contributed to this trend.
And if you guys actually want to read more on this, the cover article in the New York Times today actually talks about
if I could just have one more follow-up question to that. So you said that the socioeconomic status of these individuals plays a part in the fact that they are the demographic that is most devastated by this epidemic. I guess my question is, how can being poor make you be more susceptible to contract HIV, AIDS, and from my understanding, minority men are 8 times more at risk, yet they engage in less risk behavior than their white counterparts. And so, like, how can it be that because of the fact that individuals are poor, coupled with the fact that they engage in less risky behavior, yet they still are, more devastated by this epidemic? Like, how is that scientifically possible, logically, rationally possible?
Part of it is you have to think a little bit about micro-communities. So, for example, if you look at the epidemiology of HIV in the United States, the prevalence in almost every major city in the United States meets the criteria for epidemic, would be greater than 1% infected individuals living in that city. If you look at the city of Washington, D.C., or the city of Oakland, the rates in the African American community of HIV positivity approach 8 to 10%, which is comparable to most countries in Africa. And so you can imagine that if you look at your social circle, and if your social circle and your partners are being pulled from a community that already have a higher prevalence rate that's been established in them, the likelihood you're going to encounter a partner who's infected and acquire that infection is higher. And it is absolutely true what you say, that the data they've looked at, they're not engaging in more high-risk behaviors or riskier behaviors. If anything, it's less. But part of it is probably the fact that they're getting exposed to a higher percentage of positive partners, which probably is driving. So you can almost think of it as an amplification of transmission in those areas.
Would it be irrational to assume or to kind of believe that it's a possibility that this epidemic could be induced in these communities?
I don't think we have any data to support that.
I see.
I was wondering if you guys could speak a little bit
There, it may also be destroying some of the gut mucosa, the barrier between what's in our guts and what's in our circulation. And if you release these microbes out of the gut and into the circulation, you have one stimulus for chronic immune activation, which is what Jerome was mentioning. So in my group, one of the things that we're trying is an anti-diabetes drug. This is a drug that hit the market and basically was used to treat high blood sugars, but as it turns out, at least in our hands and in the hands of 2 or 3 other people, it does suppress chronic immune activation if you use these odd biomarkers of chronic immune activation, not direct measurements of what's going on in the gut, what's going on in the reservoir, etc. So I think there's hope. I don't know that we're going to get into these latent reservoirs with real drugs, but I think there are ways to deal with the inflammation. This is what Jerome was saying. I think there are ways of dealing with the inflammation that these reservoirs generate in the body, and if this inflammation is the cause of a lot of these comorbidities, the diabetes, et cetera, then yeah, maybe treating inflammation is one way to extend life and extend the quality of life for the patient.
Okay, so there we have it. That was WashU's World AIDS Awareness Week research panel. The panel was comprised of 3 doctors. 2 of them were healthcare providers. One is a PhD who does research. Well, actually 4 doctors. 3 were healthcare providers. One was was a PhD who does research around AIDS. So after the panel,
that's a neat trick I learned. So
everyone who attended was invited to come down and ask more questions if they had more questions from the doctors. From the doctors, to the doctors, of the doctors. And as I was making my way down to the panel, something very disappointing happened and really disturbed me.
there you go.
I was told by one of
Like 10, 15 seconds. And then
the representatives from the WashU World AIDS Council that the council, and I'll refer to it as the council because I don't want to insinuate that this is the sentiment of Washington University in St. Louis, but of this council. A representative from this council told me that the council itself was not comfortable with me I guess communicating with the panel. So I initially was kind of confused because I reached out to the council who actually organized this event, this panel, all of the events here this week around World AIDS Week here at WashU. So I reached out to them because I wasn't really sure of the format of the panel. I reached out to the council and I asked via email if someone could make arrangements for me to actually speak with a representative from Washington University School of Medicine, considering that, hey, this is Washington University, Washington University School of Medicine, and WashU does a lot of research around a lot of things, but specifically HIV/AIDS. And so I never got a response back to the email. But when like I said, basically, my thing was, if my question was received via email to the council's inbox, why was it, like other questions that I have asked via email to this council, not replied to? Is it because the act of being an organizer and a student, which I know all about, keeps you so busy that the time to reply just isn't available? Or is it because I'm not regarded with the level of respect one would have for another whose questions are worth answering? If that was the first question asked by me, ignored by this council, I would assume the former. Initially, I just assumed that the council had not received the email. I was assured that this was not the case inadvertently when I was told by a representative of the council upon my arrival to the forum that my email was received and that the council did not feel comfortable with me asking the panel of doctors questions. In spite of the fact that this event was free and open to the public, and attendees were told that the questions were welcome, said attendees also asked questions before, during, and after the panel. Is it because I asked the hard questions, the questions that no one else wants to deal with? Is that what made the council uncomfortable? I spoke with Dr. Yaroshevsky, Dr. Ansis, and Dr. Hayes, individually and collectively. They all thanked me for asking, quote, the good questions. None of them objected to me publishing the parts that I captured on video. And Dr. Hayes even made arrangements for her and I to conduct an interview where we could go further in depth. Not only once again were there other attendees asking questions, but this event was free and open to the public. This was not a private event. Also, I'm a journalist. The United States protects the freedom of press. No one has the right to suppress freedom of press. To further substantiate my point, this was a Worcester event. I'm a Worcester student. I'm on staff at Worcester's newspaper. And, you know, flat out, my objective is to get this information and resources to those who need it most. The actual faces of HIV, AIDS. Poor, hold on, let me get in focus here. Poor black and Hispanic men are the face of HIV/AIDS, and my objective, as I said, is to get this information and the available resources and all this stuff to those communities, to those individuals, to that demographic. And they'll never receive it as long as it stays in the nooks and crannies of the great halls of Wash U, where they're not welcome. I guess my last question is, what is the true objective of the council? To spread awareness or to suppress it? Well, thanks for checking out the piece. Leave a comment. Don't forget to check me out at just Google Talal Ahmad in St. Louis. All right.